also the Vice President of AOMSIKerala at present. I request Dr. Sreejith to introduce our speaker for the day, Dr. Janani Anandkumar. Over to you, sir.
Yeah, good evening, one and all. And once again, I welcome all the participants to the 10th webinar of the AOMSIKerala Institute. Dr. Janani Anandkumar, she's renowned in the medical community for her unwavering dedication to her patients and her relentless pursuit of surgical excellence. She specialized in oral and maxillofacial surgery with a focus on head and neck oncology. She's a trailblazer in the field, constantly pushing boundaries and seeking new ways to improve the patient's outcome. It's her compassion and empathy that truly made her a standout surgeon. Initiative. It is IFI leadership team, a pioneer endeavor established by the American Head Society, that is AHNS. So beyond the operating room, Janani is dedicated to research, constantly seeking new ways to advance medical knowledge in the field of head and neck surgery oncology. Her commitment to innovations and collaboration drove her to work tirelessly, always trying to make a positive impact on the lives of her patients. She has a robust track record of 28 publications and citations, and also etching decency. She already delivered 16 presentations all over worldwide and nationally. She also completed the MDS from Banaras Hindu University, Varanasi, and she was also clinical observationship in head and neck oncology, Madan Mohan Malaviya Cancer Center. That's a unit of Tata Memorial Cancer Hospital in Mumbai. She is also holding the FHNO Fellowship in Oral Oncology. That's from ASUMIMS, Kozhikode. So here with Proford, I introduce our speaker, Dr. Janani, for the 10th webinar of the AOMSIKerala State. Welcome, Janani. Kumar, over to you.
Thank you, Sreejith sir, for the introduction. Good evening, everyone.
It's very short. It's very short. Couple of almost 10 pages are there, but I will short to this. Thank you.
Thank you, sir. Thank you so much. Again, good evening, everyone. I think someone is drawing on the screen. Please don't do it. First of all, I would like to thank Dr. Akhilesh sir and AOMSIKerala for giving me this wonderful opportunity. So you all must be thinking this is my wallpaper, but it is not. So without any delay, let me move into the topic. So why I put this picture is, I think you all would have seen a sea before tsunami. So it somewhat looks like this. There is a receding of the coastal area before tsunami hits. So this is a caution and which helps people who are living in the coastal area and people who are walking on the beach. So this is a caution for them that sooner or later tsunami is going to hit. So once it hits, it's you know how bad it is. So once it hits, the damage done is really bad. And even though we try to do the damage control, what is lost is lost. So oral potentially malignant disorders, that is OPMD, can be related to this scenario, which is the tsunami and the receding thing. So this OPMD gives us a caution before the crisis hits, that is before the oral cancer starts. So this is a phase where we can, like the people gets the time to run away from the coast and save their life. This is also a phase where we can, as a dentist or as an oral and maxillofacial surgeon, we can help the patient save their life too. So, hello everyone, this is Dr. Janani Anandkumar. I'm currently doing my oral and maxillofacial, fellowship in oral oncology and reconstructive surgery at Aston Malabar Institute of Medical Sciences, Kerala. And today we are going to be discussing about oral potentially malignant disorders. which is OPMD. So there's a lot of confusion regarding the terminology right from the beginning. Some people call it as pre-malignant lesion, some people as precancerous lesion, sometimes as precancer, epithelial precursor lesions, or intraepithelial lesion. There are so many things which are confused. And two things which we will never forget, which are pre-malignant lesion and pre-malignant condition. Because we've struggled a lot in our UG and PG times to understand the definition of both. I mean, to remember the definition of both. So let's see about the evolution of the terminology. WHO in 1978 initially termed it as pre-malignant lesion and pre-malignant conditions. So the definition of pre-malignant lesion is a morphologically altered tissue in which oral cancer is more likely to occur than in its apparently normal counterpart. The example of which is leukoplakia. And pre-malignant condition is defined as a generalized state associated with the significantly increased risk of cancer. For example, OSMF. In 2007, the WHO organized a meeting which is known as WHO Collaborating Center for Oral Cancer in the UK and termed it as potentially malignant disorders. They referred to a group of lesions and conditions characterized by variably increased risk of developing cancers of the lip and oral cavity. Van der Waal in 2018 tried to change the terminology to potentially pre-malignant oral epithelial lesion, but by the time this potentially malignant disorder the term was very well accepted by the surgeons and the researchers, that there were numerous publications which were published before this 2018. So they stuck to the potentially malignant disorder. So by Van der Waal, what he was trying to portray by this PPOEL is, it is to emphasize the fact that these lesions have the potential to become malignant and that their current status may actually present a pre-malignant state. Finally, in 2020, because of all the confusion, the WHO came up with a definition which says any oral mucosal abnormality that is associated with a statistically increased risk of developing oral cancer. So everyone decided that it will not be called as a pre-malignant lesion or a condition, because not every lesion is going to become a cancerous lesion. So it is now called as the oral potential malignant disorders. So now moving on to what all lesions come under this broad term, oral potentially malignant disorders. The ones which are there from previous meeting, which have been discussed and which have been included are oral leukoplakia, erythroplakia, proliferative varicose leukoplakia, oral squamous fibrosis, palatal lesions in reverse smokers, oral lichen planus, oral lupus erythematosus, dyskeratosis congenita, actinic keratosis or actinic cheilitis. And two entities which have been newly added recently in 2021 are oral lichen node reactions and graft versus host disease. And there are also other entities which have been added. One is disorders with limited or insufficient epidemiological evidence for malignant potential, which are epidermolysis bullosa, chronic hyperplastic candidiasis, exophytic varicose hyperplasia. And the next ones are syndromes that may potentiate cancer development in the oral cavity, which includes Fanconi's anemia and Plummer-Vinson syndrome. So how prevalent it is? Mello et al. Conducted a study in 2018, which showed a global prevalence of 1 to 5%, that is 4.47% overall. The common entities were oral leukoplakia and OSMF. Oral leukoplakia was seen in 4.96%, and OSMF had a prevalence of 4.11%. There was high prevalence seen in South and East Asia region with male predominance and malignant transformation rates of over 2% per year. There was also a difference between the region where the study was done. So what is the etiology? The etiology can be classified into extrinsic factors and intrinsic factors. The most common single most major cause is tobacco in any form, either it is smoking or chewing. The second common factor is alcohol, which regardless of the beverage type and drinking pattern, it might either be solely responsible or it might have it might add up to the tobacco. The third one is infections such as HPV, EBV, HBV, HIV, and HSV, or bacterial infections such as Treponema pallidum, fungal infections such as candidiasis, ultraviolet radiation from sun, which is commonly associated with the lip lesions, and chronic inflammation or irritation from the sharp teeth or chronic cheek bite. The intrinsic factors are genetic factors, 5% of which are hereditary in nature. Immunosuppression can lead to cases such as organ transplant and HIV cases, which can lead to graft versus host disease, and malnutrition such as iron deficiency, vitamin A, B, and C deficiency. So before moving on to learning about the oral premalignant disorders, we need to know why we have to read this and why we have to have the knowledge, because some cases eventually it is going to become a cancer. So now let's see how this normal mucosa and this OPMD goes on to become a carcinoma. So it happens in various steps. So each step consists of certain genetic alterations, like you can see in this, from normal mucosa to hyperplasia, the 9p21 loss of heterozygosity occurs and CDKN2A inactivation. So in each step it occurs, and there are certain common things. These are also called as, these also can be used as biomarkers, which can detect the malignant transformation rate also. So the common ones are this LOH and TP53 inactivation and P10 inactivation. So such things. So there a systematic analysis, systematic review found that there are about 113 biomarkers that are available, but none of them are now clinically used. Everything is in the preliminary stage, and there are various studies going on. But one problem is that only 20% of these lesions of the oral cancer starts as OPMD. Other 80% lesion, they directly come as a carcinoma only. So next thing is dysplasia. So we saw from hyperplasia, it moves on to become a dysplasia, from dysplasia to carcinoma in situ, and carcinoma in situ to invasive carcinoma. So dysplasia, there are three types of dysplasia: mild, moderate, and severe. These are classified according to the level it occurs, whether at the lower level, middle level, or at the upper third, and also certain dysplastic features, which are cytological and architectural. The cytological features are whatever is given here. We have read this time and again in our UG and PG time, so I need not repeat this again. So initially it was divided like this, but WHO and everyone felt that, the researchers also felt that there is discrepancy between these things. When a pathologist is reporting, there was a lot of confusion between the mild, moderate, and severe. So what they did is they introduced the binary system in 2007, through which they divided only into high risk and low risk dysplasia. So high risk dysplasia is one in which there are more than 5 cellular changes and more than 5 architectural changes. So this is called as high risk dysplasia. A low risk dysplasia is in which there is less than 4 of each category, each dysplastic, architectural or cellular changes. So there was comparatively less confusion in reporting. So now let's see what are the malignant transformation, because to treat a OPMD, we need to know which lesion should be treated and which lesion can be left as such, because unnecessarily treating every lesion is not required. So what do we need to know is the malignant transformation rate of each this lesion. So these two gentlemen whose name I cannot even read. So these people did a wonderful study in 2019, which in which they reported the malignant rate of all these lesions. So in this, if you see, proliferative varicose leukoplakia has the highest cumulative malignant transformation rate, which is 49.5%. So it is almost 50%, and malignant transformation rate per year is 9.3, which is very high. And the second one, as you can see here, is our erythroplakia. And the third one is leukoplakia, and fourth one is OSMF. And the least dangerous thing is, I think, lichen planus here. So this is a very important one which we have to remember. So now let's move on to diagnostic tools, because visual examination is a very useful diagnostic method, but the sensitivity is only 56%, 55 to 60%, roughly. So we need other methods also. So such methods are, first one is vital staining, second is optical methods, which we use various lights like visilight, fluorescence spectroscopy, Weyl scope and all that. Next one is imaging, CT, MRI and so and so. And the recent one which is used commonly in this OPMD cases are NBI, which is narrow band imaging, which is very useful, and histopathology, which is gold standard, and all other molecular methods and the salivary diagnostic methods. So let's see one by one. First one is the Toledan blue staining, which is a commonly used technique. The technique is given by Marshberg et al., in which 100 ml of 1% Toledan blue is taken, and which is prepared by mixing 1 gram Toledan blue powder, 10 ml of 1% acetic acid, 4.919 ml of absolute alcohol, and 86 ml of distilled water, pH regulated to 4.5. So this Toledan blue stain is kept ready, and 1% acetic acid solution is made, which is prepared by mixing 1 part of 5% acetic acid with 4 parts of distilled water. So this is made and kept. So now what we do is ask the patient to rinse with water for 20 seconds to remove all the debris in the oral cavity. And second, what we do is application of 1% of acetic acid. We ask the patient to swish the acetic acid for 20 seconds to remove the ropey saliva which is present. And next step is 1% Toledan blue which we have prepared. We have to ask the patient to rinse it for 20 seconds. And next step is again 1% acetic acid rinse wash is performed to remove the mechanically retained stains. And then last step is to ask the patient to rinse the oral cavity with water. So after this, the patient's oral cavity is observed. The dark blue part which are there, which we will be able to observe, will be recorded as the positive areas, and the light blue or no color area will be considered as the negative areas. So it looks something like this. This is the lesion, and this dark blue part is the malignant area. I mean, the potentially malignant area, and this part is the will be considered negative. So how does this work? It stains the Toledan blue stains the nucleic acid in the lesion. In which case, I mean, the nucleic acid is high in cases of dysplasia and malignant cells. So the identification, it is useful for the identification of clinically occult abnormalities. And the study conducted by Allegra et al. Showed that it has a sensitivity of 96% and specificity of 80%. But the big problem in this was that it had a high false positivity rate of 30 to 55%, which means high false positivity in the sense if there is no malignancy or dysplasia, it can show that in 30 to 55% of the cases, it shows that there is malignancy or dysplasia even though it is not there. It has 7% false negative rate, which is even though there is malignancy or dysplasia, in 7% of the cases, the Toledan globe shows that there is no dysplasia or malignancy. So which is very dangerous. So, and the other negative point is that it is a subjective interpretation. It is not a fixed one. Whoever sees, if I see and I'm not in a good mood, I don't want to treat, or I don't want to, or I'm not seeing it properly, then I can tell there is no malignancy. I can miss out things. So that is a subjective negative. That's a drawback of this Toledan law. And the main thing is that there are no RCTs regarding the efficacy of Toledan blue staining yet. And there is also confusion over equivocal staining. If every region is stained the same way, so we don't know if it should be taken as positive or negative. And so the only the only utilization of this can be during biopsy. If we want to take the biopsy from the most representative area, we can stain and then go for the darker area. So that is one thing where it can be useful. Next one is the brush biopsy. So it is the collection of transepithelial sample of cells. So this is based on the loss of cohesion, the concept of loss of cohesion in the malignant cells. So because of loss of cohesion, what happens is the cell gets accumulated on it just lies on the surface. So brushing, with the brushing, all these cells which are transepithelial cells can be removed along with the brush, and it can be taken for a biopsy. So the problem here is it is very good in a malignant lesion, but there is no loss of cohesion in OPMD. So it's effective in OPMD cases. We don't get any representative cells. And this is also not a confirmatory diagnosis. We cannot take brush biopsy and go on to treat the case. We need a histopathology to treat the case. So that is one thing. And study shows that it has a sensitivity of 79% and specificity of 94%. And same as Toledan blue, this also has high false positivity, which is a huge drawback. Next is chemiluminescence, which is commonly Visilite, or the brand name is Visilite or Microlux or whatever. So what they do is they use a blue-white light. So what this lesion does is wherever there is keratosis, this blue light is reflected. So it is seen as highly opaque region. So wherever there is highly opaque region, there is high chances of harboring malignancy. So what is done is 1% acetic acid wash is given for 30 to 60 seconds for the patient, and the light is shined to the oral cavity on the mucosa. So this differentiate normal and abnormal the mucosa. And R. Nagi et al. Did a study, and they found that the sensitivity is 77 to 100% and specificity is 0 to 28%. So again, this doesn't have a strong evidence, and there is no RCT here. So next one is tissue fluorescence imaging. This is based on tissue autofluorescence. There is change in structure and metabolism of epithelium, and stroma alters their interaction with light. So in such cases, when the fluorescent light is flashed, the abnormal mucosa is seen darker in color. As you can see here, the abnormal mucosa, or where there is dysplasia, it is seen as darker in color because of decreased autofluorescence in that region. So again, this doesn't have any RCT, and there is no strong evidence to support this. Same way, this can be used in cases of biopsies. Next is fluorescence spectroscopy. It has a similar principle, and it involves tissue exposure to various excitation wavelength. The only difference is in this, according by calculating the autofluorescence spectra, the lesion can also be classified into squamous cell carcinoma, leukoplakia, oral submucous fibrosis, and normal squamous tissue. So this is an advanced form of the fluorescence that the previous one. And Pankaj sir has done a wonderful study which shows that the sensitivity of this fluorescence spectroscopy is 98% and specificity is 100%. The last one is the hero. Now it is being more commonly used. It is the narrow band imaging, which enhances tissue contrast by identifying superficial capillaries and neoangiogenesis with abnormal tissue. Actually, when there is a carcinogenic activity in that region, there is neoangiogenesis and small capillaries. All this starts to come in that area. So in this, what happens is color filter is used to narrow the bandwidth of the spectral transmittance. So we can see these small capillaries, and with the shape of the capillaries and the color of the capillaries, it is differentiated into normal oral mucosa and abnormal mucosa. Normal mucosa appears cyan in color and has clear, cyan means kind of blue. So it is a mixture of blue and green type. So it is that in color and has clear branching vessels in subepithelial layer. And abnormal mucosa, it is the vessels are loose, regular capillary arrangement and appear brown or on dilatation. There are 4 types of this vessels which are seen in the normal NBI. Type 1 and type 2 are, type 1 is a small comma like one small R like this blood vessel, which is a normal one. Second is it is a loop like one. Second is a larger one, which is also a normal. So type 3 and type 4 are, they don't have the loops. They are long, elongated, this dark color capillaries, brown color capillaries, which are considered dysplastic or malignant. So this is a done study, very nice systematic review done in the Cochrane library, which is the screening programs for early detection of prevention of oral cancer. And it was recently done. And what they have told is visual examination as a part of population-based screening program reduces the mortality of oral cancer in high risk individuals. So visual examination is a decent method of screening. And there is also a state shift and improvement in survival rate across population as a whole, just with visual examination itself. But one shocking thing what they told was, there is no evidence to support the use of adjunctive technologies like Tolidine blue, brush biopsy, fluorescence imaging, even NBI as a screening tool to reduce the oral cancer morbidity. So nothing plays a major role. So visual examination is quite, decent. So next is the biopsy, which is the actual hero, the gold standard of diagnosis. But when we talk about biopsy, we are the next question which comes to our mind is where to biopsy. So where to biopsy? The answer is most suspicious or abnormal looking site. So in this case, this is the abnormal looking site, because when there is a homogeneous, when there is a mixture of heterogeneous lesion, there is homogeneous area also, heterogeneous area also. We obviously go for a heterogeneous area like this for biopsy. In this type of lesion, obviously we'll go to this, we take some normal mucosa also, some edges, and we also have to keep in mind the anatomy also. Here the duct will be there, so we have to we should not do it in this area. So this area will be, or this area, whichever is away from the anatomical structure, important structure. So next is prevention. Prevention can be done in 3 ways. First one is primary prevention, which is by habit cessation. Second one is the secondary prevention, which is by screening and early detection and treatment. Third one is the tertiary prevention, which is prevention of the second primary. So when we talk about pre-malignant lesion and screening and everything, it will be a sin not to talk about this wonderful study which was done in Trivandrum by Sankaranarayan et al. The study is called as TOC study, which is Trivandrum Oral Cancer Screening Study Group. It is one of the pride of our country, because it was done in 1996, and you will be amazed to see how many patients were included. So there were 13 clusters were included, and totally there were like one cluster itself, there were 96,000 people, and the other cluster also had around 96,000 people. So it was done in collaboration with International Agency for Research on Cancer. And so the question what they had in mind is, will a visual inspection based screening program lead to substantial reduction in oral cancer mortality? So there were 7 clusters. One cluster, there were 13 clusters, 7 clusters were screened and 6 clusters were just given health education. The screening was done by trained health workers, not by doctors. They were trained health workers who examined the patient, and they had a book which had pictures of all the lesion, suspicious lesion, and the lesion they had to see these patients, and they have to refer the patient. They have to classify it as referable lesion. If there is any lesion, they have to classify it as referable lesion and non-referable lesion. So in these patients, so many patients, they had 5,145 screen positive. That is, they had some lesion, and 63% of these patients compiled with referral. That is, they went to a dentist or someone, clinician, to get it biopsied. So the result of this study was that in entire population, health education plus screening had a death of 16.4 out of 1 lakh population, 16.4% of 1 lakh population, and only health education had 20.7%. It was not statistically significant. But in high risk population, that is patient with habits, so this health education plus screening, they had 29.9% deaths, whereas only health education had 45.4% of deaths. So they concluded that they had a higher percentage of early detection when there was screening, and that oral visual screening can reduce mortality in high risk individuals and has the potential of preventing at least 37,000 oral cancer deaths worldwide. So that is about screening and prevention. So let's move on to seeing some of the few important and most common OPMDs. The first one is leukoplakia. There's a lot of fuss about this definition of leukoplakia. So the WHO in 2007, they said it is a predominantly white plaques of questionable risk having excluded known diseases or disorder that carry no increased risk for cancer. Van der Waal, he always comes up with another some other definition. So what he said is, it is a predominantly white plaque or patch that cannot be characterized clinically or pathologically as any other definable lesion. So I think we went with Van der Waal only because I remember reading this definition only. So how do we diagnose it? There was a group formed, working group who came up with this diagnostic criteria in 2020. So they said that a lesion can be classified because it is a diagnosis of exclusion. It is not, we cannot pathologically say it is a leukoplakia. We cannot say because pathologically there is nothing. It is clinically done. Pathologically, you won't have any proper feature that says it is a leukoplakia. So if there is these things are not there, it is called leukoplakia. So it is a diagnosis of exclusion. So they gave a criteria which says it should be a predominantly white patch or plaque that cannot be rubbed off first. Second is most homogeneous leukoplakias affect a circumscribed area and have well demarcated borders. A smaller subset can present with diffuse borders. Third is non-homogeneous leukoplakias, typically present with more diffuse borders and may have red or nodular component also. Then no evidence of chronic traumatic irritation to the area should be there. The next one is it is not reversible on elimination of apparent traumatic causes. Then it becomes a traumatic ulcer. Right. The next thing is it does not disappear or fade away on stretching. So then it becomes a leukoedema. So all these things should be excluded in order to diagnose it as a leukoplakia. So these are some of the DDs of leukoplakia which has to be excluded before we tell it as a leukoplakia. First one is white spongy nevus, which is noted in early life. It has family history. The lesions are throughout the mouth, and genital mucosa may also be affected. The 4-day spots or condition, which is less than 1 millimeter in diameter. It is elevated, is circular of colored spots or papules distinctly demarcated from the normal surrounding lining mucosa. Next is oral lichen planus. They are white papules joined up with lines to form reticular appearance, which we'll see pictures, we'll see later. Next one is nicotinic stomatitis, which has grayish white palate with red spots, and patient has a definite smoking history. Leukoedema is already we have seen, it is bilateral on the buccal mucosa. It disappears on stretching, and it has a blue tint also. So next one is frictional keratosis. History of friction or other mechanical trauma is there in this case. And biting of lips or commissures or cheeks should also be excluded. Next one is chemical injury, which has a known history of chemical exposure. Then acute pseudomembranous candidiasis, which is generally widespread. The white membrane can be scrapped off in this case, which cannot be scrapped off in leukoplakia. So there are two types, homogeneous and non-homogeneous. Homogeneous is uniformly flat, thin, and it has a smooth surface and shallow cracks. It is asymptomatic in nature most commonly. Non-homogeneous types are speckled, nodular, or verrucous or exophytic type. The speckle might have mixed white and red lesion. Nodular has small polypoid outgrowths, and verrucous or exophytic has wrinkled or corrugated surface. The homogeneous, these are the pictures which shows homogeneous lesion. The malignant transformation rate is 3%, whereas a non-homogeneous lesion is a nodular, and this you can see nodular, and this has some red count part to it, and this has a malignant transformation rate of 4.5%. So Van der Waal again came. So what he did now is he classified it into different types according to the size of the lesion, less than 2 centimeter, 2 to 4 centimeter, more than 4 centimeter, L1, L2, L3. He wanted to bring a staging to this. So he got a staging according to the size and the dysplasia, the severity of dysplasia, right? So next in so these people always if one brings something, the other brings something else. So WHO also came up with something, and now they divided into stages. First, they said phase 1. Phase 1 is thin smooth leukoplakia, which has better prognosis. So it progresses from phase 1 to phase 4. So phase 2 is thick fissurated, like you can see it here. Thick fissurated leukoplakia. Stage 3 is proliferative verrucous leukoplakia, which has a higher malignant transformation rate, which we saw first, if you remember, 50%. And phase 4 is erythroleukoplakia, which has a very poor prognosis. So, what are the high risk? Are we going to excise all leukoplakia? No. We are going to excise only leukoplakia, which has high risk factors. So, what are these? So, this also, Saman Varnakul Surya, he brought up these factors in 2021 along with his co-workers. So, what he said was the patient should have who has a previous history of head and neck cancer, female gender, long duration of leukoplakia, patient age more than 50 years, size more than 200 millimeter square, non-homogeneous type, and location in lateral and ventral surface of tongue, floor of mouth, and RMT and soft palate areas, presence of Candida albicans, and presence and degree of epithelial dysplasia. All these presence and degree, which is severe, high risk dysplasia. So all these factors come under high risk factors of leukoplakia. So all this should be treated, surgically treated. So what if we don't treat the leukoplakia? What will happen? So Silverman et al. Did a study, which is an Indian study, national study. So in this cases, what they just left without treating the leukoplakia. In that case, what happened? 11 had regression. 56.7% did not, nothing happened. It just remained the same. And 31.6% of cases, it progressed. Penberg et al., this is an international study. They saw that there was regression in 3.3%, and it remained the same in 58.8%, and it progressed in 37.9%. So therefore, around 30 to 40% it progresses. Next one is erythroplakia. It is a predominantly well-demarcated red lesion with flat macular velvety appearance that may be speckled with white spots, which cannot be clinically or pathologically diagnosed as any other condition. It can either be a homogeneous erythroplakia, a granular erythroplakia, or a speckled erythroplakia. So most of the clinically diagnosed erythroplakia represented severe dysplasia or carcinoma after biopsy and histopathological examination. 51% were well differentiated oral squamous cell carcinoma. 40% were carcinoma in situ or severe epithelial dysplasia, and 9% were mild to moderate. So it has a very high rate of malignancy, and so therefore early and immediate wide surgical excision is recommended. Next, moving on to the proliferative varicose leukoplakia, which has almost 50% of malignant transformation rate. There is no second thoughts while seeing this type of lesion, and we just directly go for an excision. So it is usually common in older women, 4:1 male-female ratio. Lower gingiva is commonly affected. The carcinoma may be present at primary examination. And the treatment is undoubtedly excision. So there are certain criteria which has to be fulfilled to be called as a proliferative varicose leukoplakia. First, major criteria are a leukoplakia lesion with more than 2 different oral sites, excision of varicose area, lesion have spread or engrossed during the course of the disease, recurrence in a previously treated area, histopathological diagnosis. And minor criteria are leukoplakia lesion occupies at least 3 centimeter when adding all the affected areas. Patient is female, patient is a non-smoker, disease evolution occurs, disease evolution higher than 5 years. So these are the criteria. So now, this is a flow chart which tells us the management of leukoplakia. So the first thing what we do is elimination of the possible cause and observe for 2 to 3 weeks if there is a possible cause. So in that case, we wait for 2 to 4 weeks and see if there is good response, then it must be a definable lesion which is managed accordingly. If there is no response, then we go for a biopsy. If there is no possible cause at all at the beginning itself, then we directly go, which cannot be eliminated, of course. So we go for a biopsy, and this biopsy, if it is histopathologically proven diagnosis, if we get, then if it is dysplastic leukoplakia, then we treat or observe lifelong and follow up to 3 to 6 months. If it is non-dysplastic, then treatment is given accordingly, and it is also observed for 6 to 12 months. So in non-dysplastic leukoplakia, mostly surgical excision is not done. That is why a longer observation is required. And if there is moderate to severe or high risk dysplasia, then we have to upfront go for a excision. If it is a definable lesion, anything apart from the leukoplakia, then it should be managed accordingly. I hope it was clear. Again, we will be seeing this table again in a different method. So management non-surgical, first one is quitting habit. Second one is topical antifungal if there is a fungal infection. And vitamin A, curcumin, all this pharmacotherapy can be given. And photodynamic therapy can be used, and patient can be encouraged to include a lot of leafy vegetables and all this guava, papaya, and all that in their diet. And also surveillance is very important. Surgical is excision. Either it can be done with the scalpel or laser excision. The best laser is CO2 or electrocoagulation, or cryosurgery can also be done. So that is about leukoplakia. Next one is oral lichen planus, which has the least malignant transformation rate. It is a chronic mucocutaneous disorder of stratified squamous epithelium of uncertain etiology that affects oral and genital mucous membranes, skin, nails, and scalp. The lesions are frequently bilateral and symmetrical, and desquamative gingivitis may also be a feature. So it is most commonly seen in females between the age of 30 to 60 years. The etiology is commonly autoimmunity and genetical predisposition, drugs, certain dental materials which causes irritation, and infectious diseases such as HCV. Stress is also a major cause for lichen planus, and also comorbidities such as diabetes and hypertension. So they can also have skin lesions like how you what is seen in the picture. So there are different types of 6 types of lichen planus. First one is the reticular lesion, which is the most common one, which you can see as becomes striae, which is the characteristic feature of reticular lichen planus, as you can see in the picture. Second one is annular lichen planus, which you can see in the picture. Third is plaque type of lichen planus. Fourth is erosive lichen planus, which have a erosive component, and bullous lichen planus. Last one is the pigmented lichen planus. So the treatment is topical steroids such as triamcinolone or clobetasol with aura base, and tablet betamethasone can be crushed with butter, and it can be applied in the buccal mucosa. And in recalcitrant cases, topical cyclosporin or topical mycophenolate mofetil, which is an immunosuppressive drug, can be used. Intralesional dexamethasone can also be injected bi-weekly, which is long-acting and less viscous in nature. Local drug delivery stents can be used to keep the this medicatives in contact with the buccal mucosa or the gingiva, the local site. So all these treatments should be done at least for 15 to 21 days. So this is a picture of the drug delivery stents in place. Next is the immunomodulators, which is used for 3 to 6 months after laser excision. Medicines such as dapsone 100 mg OD, hydroxychloroquine 200 mg BD, or azathioprine 50 mg OD can be used. Next one is also a common entity which we see in practice. It is the oral submucous fibrosis. So Pinbob defined oral submucous fibrosis as a chronic insidious disease of the oral mucosa and sometimes the pharynx, although occasionally preceded by and or associated with vesicle formation. It is always associated with juxtaepithelial inflammatory reaction. That is the important word, juxtaepithelial inflammatory reaction, followed by fibroelastic change of the lamina propria with epithelial atrophy, leading to stiffness of the oral mucosa and causing trismus and inability to eat. So the etiology, the common etiology is areca nut, which has 3 agents in it. First one is the alkaloid, second one is the polyphenols such as flavonoids, and third one is the trace element. So what does these do? Alkaloids has reactive oxygen species, growth factors, and this matrix metalloproteinases. All these combine together to form to decrease the vascularity of the epithelium, the mucosal membrane, and also it increases collagen production, decreases collagen degradation, and also causes abnormal cross-linking. All this combined to form atrophy of the epithelium. And the trace elements such as copper causes cytotoxicity. All this leads to atrophy, which in turn leads to the inflammatory reaction, fibroelastic change, and so on. So Khanna and Andrade in 1995 classified it as 4 groups. First one is very early, second early, third moderately advanced, and advanced cases. Very early cases, it is only burning sensation, acute ulceration, recurrent stomatitis, and the mouth opening is more than 35 millimeter. In early stage, the buccal mucosa is mottled in nature, and the mouth opening is between 26 to 35 millimeter. In moderately advanced cases, there sets in vertical fibrous bands at the soft palate, pterygomandibular raphe, and anterior fossal pillars, and the mouth opening is between 15 to 25 millimeter. In advanced cases, it is less than mouth opening is less than 15 millimeter, and there is thickened fossil pillars, shrunken uvula, circular bands around the entire lip, and restricted tongue movements. So we can see that there is restricted mouth opening, there is perioral fibrous bands. Here you can see fibrous bands at the RMT and fossil pillar region. There is deep papillation of the tongue. There is severe restriction in mouth opening, and there is thinning of the lips and deviation of the uvula. All these are features of OSMF. So for first and foremost thing, what should be done is habit cessation, followed by pharmacotherapy, physiotherapy, mouth opening exercises, and also in early lesion, very early and early cases, we can also go for dexamethasone injection, that is intralesional steroid injection bi-weekly, 2 times a week for 6 to 8 weeks. And if there is any suspicious cases, suspicious lesion, because most of the cases comes, which has a very advanced, advanced stage, has the restricted mouth opening, and there might also be lesion inside the oral cavity, cancerous lesion inside the oral cavity, which might be missed out. So those patients must be examined under anesthesia to look for any suspicious lesion. In case biopsy should be done. And pharmacotherapy. So in pharmacotherapy, the most commonly used drug which I have seen is the SM Fibro, which contains lycopene, beta-carotene, selenium, zinc sulfate, and all these things. But is it really helping? That we will see later. Other things such as curcumin, oral pentoxifyl, and all these are there in clinical practice, but there are no robust evidence supporting this usage. So surgical therapy is there is a protocol which is commonly followed, which recommends first step to be surgical release of fibrotic bands by fibrotomy or submucosal resection, and followed by coronoidectomy or bilateral temporal myotomy, and extraction of all the third molars, and reconstruction of the defect with graft or any flap, which can be either a local flap or a distant flap, and oral stents to prevent the formation of fibrosis again, and also aggressive physiotherapy following the surgery, which should be started immediately. Next one is actinic cheilitis, which is most commonly due to long-term sun exposure, UVB rays, and it is commonly seen in fair complexion cases. And it is also called as farmer's lip or sailor's lip because they are exposed to sunlight. Vermilion border of the lip is usually the place where it is seen, and the malignant transformation rate is 10 to 15%. There is redness, edema, cracked, crusty lips. There is white plaques or vesicles also seen, and it is crusted, which has increased chances of malignant transformation. So the treatment is limiting the sun exposure and applying moisturizers, topical imiquimod 5% or 5 FU is used for 2 to 3 weeks. Electrocautery, cryotherapy, or carbon dioxide laser excision is recommended, and vermilionectomy and mucosal flap to close the defect after excision is done. So these are certain normal variants of the oral mucosa. One is the linea alba, which is the linea alba buccalis, which is the white line which is seen at the junction of the in the buccal mucosa, where the upper and molar teeth touches each other. So that should not be mistaken for a OPMD. Next one is the 40 spots, which we had seen, which we had already spoken about, which just looks like this. Then the leukoedema, which disappears on stretching. It has a blue tinge. Then geographic tongue, which is also not a pre-malignant lesion or OPMD. So to summarize, this is a wonderful table which is given in this by Peters A. Brannan et al. So they have devised this. So first, whenever there is a white lesion, clinical assessment should be done. Predictive risk assessment for head and neck cancer should be done, and assessment should be done under white light with magnification, and a clinical photograph at all visits should be taken so that we can compare it with the revisit. Whether the because it is a lesion which we will not remember whether it has decreased in size or increased in size. So a photograph is important, and further examination with assistance of optical fluorescence imaging or narrow band imaging can be done. So in such cases, it can be either three things. First is erythroleukoplakia, or leukoplakia or any other OPMDs. So in leukoplakia, it can either be a proliferative varicose leukoplakia or a conventional leukoplakia. Okay. So in conventional leukoplakia, it can either be leukoplakia with dysplasia or without, or it can be a homogeneous disease. So in presence of dysplasia, it can be either be yes or no. And in homogeneity, it can either be yes or no. Right. So in such cases, if there is presence of dysplasia, it can either be severe, moderate, or mild. So in this, you can see all the things marked with S. They are called as the S lesion. All the things marked in red, they are called as the S lesions. So what happens to all these S lesions is they are excised. Erythroplakia, proliferative varicose leukoplakia, and presence of dysplasia, severe dysplasia, all these are directly excised. So complete excision. So what is that is F, which is F and G. So F is complete excision with reconstruction as required. Elimination of modifiable risk factors for oropharyngeal cell carcinoma and indefinite follow-up every 3 months. Okay. And then G is biopsy or excision is undertaken with assistance of optical fluorescence. So if it is a small lesion, so then it can be excised completely, or if it is a bigger lesion, then biopsy should be taken with the help of optical fluorescence imaging or NBN or a band imaging if it is required. If it is a complete excision, if it is a lesion of less than 2 to 3 centimeter, then complete excision can be done. This is D, which is homogeneous. If it is homogeneous, then if it is less than 2 to 3 centimeter, complete excision can be done, and it can be followed up every 6 months. So what is E? E is if there is moderate or mild dysplasia, then complete excision should be undertaken if acceptable postoperative function is achievable. If function cannot be achieved, then we can take a little bit of risk and we can follow up the lesion. Okay. So I think that is clear. So now, when there are certain warning signs, apart from the lesion itself, there are certain other things which should warn us to go for a excision or a biopsy, not excision, I'm sorry, a biopsy. So what are these warning signs? First one is significant weight loss, which can indicate a malignancy, some malignancy going on. Next one is ulcer with exophytic margins. So these things also should be considered as a malignant lesion. Then referred pain. Usually, tongue, there is a separate, usually referred pain from oral cavity malignancies are to the ear. So these cases, there is some malignancy going on in between. Underlying malignancy is going on. So we have to consider it as a malignant lesion. Then pain or numbness. Pain also indicates an infiltrative lesion and numbness indicates a perineural invasion of the malignancy. So these also should be considered as malignant. Next is ill-fitting denture, which also hurts. So in such cases, there is some bone involvement and some expansile lesion or something like that should be suspected. Then a lump in the neck, either it might be a cervical lymphadenopathy or some other suspicious thing going on in the neck. So that also should be taken with caution. Next is any lump or thickening in the cheek. So there might be some lesion in the buccal mucosa, which might not look very suspicious, but there is a lump or thickening in the cheek. So which says that we should be suspicious of a infiltrative lesion with skin involvement. So, sorry. Next is voice change. Voice change also signifies there is some malignant thing going on inside. Either it can be what do we call it? Second primary tumor in the vocal cord or something like that. So it should not be ignored. Next is loosening of teeth. Obviously, there it's we should suspect bone erosion, very silent bone involvement. So in that cases, it should be considered as a malignancy. Next is difficulty in moving the jaw or tongue. So that also says there is something fishy going on there. Tongue, there is some, if the extrinsic muscles of the tongue is involved, there will be difficulty in movements, and jaw also, if there is any difficulty. So it should be taken as a trismus. Trismus will be there in many cases. In RMT region, the lesion might not be seen that grossly, but there will be infiltration which can cause reduced mouth opening. The last one is difficulty in swallowing or chewing. This also should be taken with the suspicion. So the last uh, part of this topic is chemoprevention, which is being widely researched. So it started in 1976 by Spahn, who was the first to introduce the term chemoprevention, and which can be natural, synthetic, biological, and chemical substances that possess anti-carcinogenic action. So this can be incorporated into secondary or tertiary prevention. So there are various things. These are some of the natural chemopreventive agents, which are the green tea, blackberries, lycopene, resveratrol, curcumin, and beta carotene. So retinoids are the most commonly used one, vitamin A, as the chemo prevention, and I see a lot of people prescribing vitamin A. So it is a group of chemical compounds comprising of vitamin A. Retinoids decreased free radicals, induced apoptosis, and downregulated epithelial proliferation. So it plays an important role in chemo prevention. So this study done by Gorski et al., which says it has a complete response in 10 to 27% of patients and a partial response in 54 to 90%, which is a very good number. And but the drawback is that recurrence of leukoplakia was reported after withdrawing the medication in approximately 50% of patients. So that is one of the bad thing of this. A study done by Hong et al., which showed that isotretinoin administered at 1 to 2 mg per kg per day, it showed 67% of the patient tested showed clinical response, but it had high toxicity and recurrence. So that is something bad. Next one is the green tea, which is called as the Camellia sinensis, which is a component of the class of polyphenolic agents. And it consists of 4 agents, which are the API. I don't even know how to read this. AC, ECGC, and all this so and so. So these things, what do they do is it has anti-carcinogenic and antioxidant activities. So this EGCG can regulate the expression of the epidermal growth factor receptor. So that is the main hero here. What he does is he regulates the expression, and what they have seen in the study is that smokers who consume tea extracts for 4 weeks have shown a decrease in DNA damage in the oral squamous cells. But this is not a phase 3 or phase 3 study. This is a phase 2 study. And there are no RCTs which are available. But these are not the actual problem. The actual problem is this. This is the actual problem. So, apart from all this, there are various agents which are vitamin C, beta carotene, lycopene, Bowman's Burke inhibitor. Almost everything has a antioxidant property, anti-proliferative property, anti-infiltrative property, and all this they are given in different studies. I've went through a lot of papers. They have different schedules and different dosages for prescription. So there is bleomycin, EGFR inhibitor, COX-2 inhibitor. This inhibits angiogenesis and metastasis, and celecoxib can be given. Curcumin is there are various studies going on with the curcumin, which has antioxidant, anti-inflammatory properties, induce apoptosis, anti-proliferative property, anti-angiogenic property. So it is given in 400 mg lozenges for 3 months, and topical application also can be done. Although there are studies which proves its efficiency, but there are no RCTs. There are huge trials which are going on, I'm aware of, which will take a while for the results to come. So it metformin also, it is an anti-hyperglycemic agent. It induces apoptosis. So these are trials are being done in individuals who don't have any comorbidities, and so so that it doesn't affect the other factors. So vitamin E is also has antioxidant property, anti-inflammatory property, and alpha tocopherol is given. But the problem is there are decades of research has been gone into this chemo prevention, but nothing is still in clinical use. There are a small sample of the population are taken into for the research, that is phase 1, phase 2 studies only. There are no RCTs, and the studies are done on cell culture or animal studies. So there is no human trial which has been done. It is being done, but it is not. There's no huge trial which has been published, which has a groundbreaking result. And we should also keep in mind there is high toxicity. We are not aware because we are not aware of the toxicities. Like retinoid has bone changes, and curcumin has liver toxicity in a very high dose, not in a minimal dose, but it might have very rarely. But these should not be forgotten, because we tend to, patients are also very sometimes very pestering. They start asking you to give something, so some vitamin we give, but still it should be kept in mind that they do not have a proven, there is no robust evidence for using all this. So it is better to restrain from giving this, and rely on cessation of the habit. So I would like to conclude that first thing what we understood from the entire presentation is that there is no uniform guideline for managing a whatever I was explaining is all according to the studies. There is no proper, like NCCN is there, NCCN guideline is there for cancer management, oral cancer management. There is no proper universally accepted guideline for a management of an OPMD. So the main thing, the key to prevention is habit cessation and or removal of the etiology, and to properly diagnose and treat the lesion, we have to know the lesion. So knowing the lesion and knowing the DDs is also very important, because pre-malignant or OPMD, it can be treated, most of the things are treated with topical corticosteroids. But using a topical corticosteroid in a oral cancer, which has already turned malignant, is a very dangerous thing, because it is going to suppress all the symptoms. There is no inflammation, there is no pain or anything, and silently the cancer is growing inside. That's a very dangerous thing. So we have to know what we are seeing and what we are dealing with. And whenever we are in doubt, it is better to go for a biopsy. And pharmacotherapy, there is no strong evidence. Excuse me. As we have already seen, there are many things which are used, but many studies have proven that there is no, it is not that very helpful. So next one is use of topical steroids with caution, as I told before. And the last and important thing is, whenever we are in doubt and whenever we are in confusion, there is no harm in asking a friend or referring it to another patient, because we will be each one are treating. OMFS is a very wide, large fraternity which has different things. Some are doing aesthetics, some are doing cleft and craniofacial surgery. So everyone will not have complete idea of this OPMDs. So we should not feel bad to refer it to another friend or discussing it a friend, because always thinking with two minds is better than one mind. So we can include people and discuss and then take a decision. So that is from my side. I hope it was informative, and I've done some justice to the topic. Thank you.
Thank you, Janani, for that wonderful presentation. Now I think it's open for discussion. Sreejith sir, I think there are one or two questions in the chat box.
Yeah. You have a query, Dr. Janani?
Yes, I'm just reading the.
Yeah, please. My question is about use of this virgin coconut oil.
Sir,
Is there any?
no, sir, there is no proper evidence for It is being used, but there is no phase 3 trial for anything to support the efficacy. So, as far as I know.
Lot of studies are going on, I think.
Yeah, going on. There are a lot of studies are going on, but nothing is published yet. May I know the efficacy of SM fibro in OPMD? Yeah, that is, as I said already, it has lycopene and all this chemopreventive agents in early stages, maybe in stage 1 or 2. It might be, but that is also not proven, because everything we talk about regarding with the evidence only. So there is no evidence, no RCTs, because we accept something only if there is an RCT that is proving it. So maybe in early stages it might have some effect, but not in stage 3 or 4. If biopsy reveals malignancy, how soon the surgical intervention to be done to prevent dissemination? As soon as possible. If biopsy is proven, it's better to go as soon as possible.
Yes. I think there missed one question in the beginning from Dr. Jasbir Singh. What is the definitive treatment protocol for stage 2-3 OSMs, ma'am?
Definitive treatment protocol for definitive. So there is a protocol which is put forward by Datarkar sir and his team. So that is what I had for stage 3. It is stage 1 and 2 and stage 3 and 4. So we can say it is stage 3 and 4. So stage 3 and 4, whatever I had, I'm sorry, I'll just go back to those slides. It is fibrotomy followed by coronodectomy, followed by removal of all the 3 molars and reconstruction and aggressive, followed by aggressive physiotherapy and oral stent placement. In stage 2 and 3, we can go for habit cessation, mouth opening exercises, and intralesional corticosteroid injection, biweekly injection.
There are one or two questions more. There's a question about guidelines for verrucous carcinoma.
I don't think that comes under this. I know who asked that. I think I'll answer him privately. I don't think that comes under the.
That's all right. We'll skip that. Now the next question is about mixing. How effective is curcumin and even use of butter? Even tomato juice also contains lycopene, right? So will it be beneficial for patients to prevent recurrence?
Yeah, to prevent recurrence, it can be used, but it is not recommended to use unless until you are in a trial. So actually, if you are in a trial, you can use all this. But I know people. I mean, it is used in common practice, but there are certain major trials which are going on in this with curcumin and metformin, which I know of, which I am a part of. So in secondary primary tumor prevention in previously operated cases. So that is a huge trial, which is like there are many centers involved. So that we are awaiting the result. The trial is just going on. So, but there is no other trial which is already being published. But as a preventive measures, it can be given. It will be beneficial. But there are no studies supporting it. There are studies supporting it, which is phase 1 and phase 2 studies, which are the in vivo studies. In vitro studies, it is not, there is no study which is significant, which shows a positive result. Or studies with, with very less population. There are studies like that, but it is not accepted as a groundbreaking study.
another question about if reconstructed free flap, also fibrosis in OSMF, how can we manage?
If we have reconstructed it with the free flap, if we have properly removed the fibrous tissue and we have done fibrotomy, I don't think it should fibrose again.
Yeah.
If anyone else has any idea, you can enlighten me.
Actually, Senthil Murugan, ma'am, yes, ma'am. Would you like to take that question, ma'am? Yes, ma'am. I think Senthil sir was here. Yeah, please go on.
Yeah, thank you, Janani. That was quite comprehensive. Nice presentation. Regarding OSMF, the treatment is mainly symptomatic. It is aimed to improve mouth opening for a patient. And I don't have experience of doing OSMF with a free flap, but my general management that I have seen with the local based flaps is what happens is this surgical fibrosis is something you cannot deny. And in the background of existing fibrosis and tissue changes, surgical fibrosis sometimes can add on to the limited mouth opening scenario. So this is something which we need to intervene to help the patient improve some of the mouth opening. When reconstructed with free flap, as she said, we can't really predict, can we? Once there is a good integration and if there is a onset of disease into the flap, we can, I don't know if Senthil was here, it would have been fine, but it is a possibility that I would think, it being a very generalized condition, you cannot really delineate boundaries of, okay, the disease ends here or the disease ends here. It's just a condition.
That is why we immediately start the physiotherapy. Post-op day 1 and 2, we start the physiotherapy in such way.
Yeah, but correct, ma'am. But most patients over time, they actually fatigue to physiotherapy because it's painful. And there are some that adhere to it very judiciously and they continue to have like 30 to 35 millimeters.
They have good results.
Yes, but most patients, they fatigue over time. They just don't follow it up very judiciously. And it, then you're looking at like a bad scenario again. This just has to be kept in mind. Thank you. That's my contribution.
Thank you, ma'am.
Thank you, ma'am. Naresh Sharma sir is here. Sir, would you like to add anything to that, sir?
Yeah, I think no more questions, right?
Sorry, sir.
Is there any other questions?
Yes, sir. I was asking for his opinion. Dr. Naresh Sharma is here. Sir, your microphone is muted actually. Naresh, sir.
Okay. Yeah. Regarding fibrosis in the grafted tissue, what my experience is that if you are using a pedicle graft, what we usually use is buccal pad of fat or platysmal flap or island nasolabial flap. So in those cases, particularly in nasolabial, I have never seen fibrosis. But when we graft it with the buccal pad of fat, then in those cases, we might get the recurrence of the disease. But if the pedicle flap is taken with the skin, then in those cases, we never find. Hello?
Yes, sir.
For free flaps also, it should not fibrose. No, sir. Naresh, sir.
Yeah, it should not. Yeah, it should not fibrose.
Okay.
Yeah, it should not fibrose.
Yeah. My experience with OSMF has been with nasolabial, with buccal fat pad, and also skin grafts. Skin grafts were really bad. Buccal fat pad, to some extent, they did well. And nasolabial also, after some time, I think it could be a combination. It could be that patient was not following up also. I mean, doing the physiotherapy part. So it comes back to square one after like a year and a half.
Probably it can be more in cases with split skin graft.
Yeah, possibly.
Possibly.
Yes, sir. Thanks.
There are 1 or 2 questions more in the chat box. What is the role of antioxidants? I think you have explained that already. Would you like to add anything more to that? Dr. Janani, what is the role of antioxidants in oral mucosal lesions? And again, one more question is regarding the management of recurrent OSMF who had already undergone aggressive therapy. Is there any protocol? These are 2 questions in the chat box.
That I think we have already discussed.
Yeah, we have discussed it already. There's another question. What is the treatment protocol for patients with 4-diasis granules if it is a concern for the patient?
Usually it is not a concern. If it is painful, I don't know, sir. I'm really not aware of this.
Okay. No, I don't think it.
Uh,
I think
may
the
I-
patient.
May I
Please, ma'am.
chip in here?
Yes, ma'am. Yes,
Yeah,
ma'am.
please, ma'am.
Yeah, so I think it's important as clinicians to allay the patient's anxiety and let them know that this is, it's benign and it's not
Yeah.
a disease. It's just 4-diasis granules. If you want, if the patient is quite anxious, you can biopsy to confirm it is normal. But that's it. There is nothing else needed, and it is up to us to convince the patient and allay their anxiety, saying this is nothing to be worried about. You're just fine. I think we really need to work on our skills for that.
There is one more question. Which flap is ideal for extensive OSMF involving both buccal mucosa and labial mucosa, ma'am?
Buccal mucosa and label. As sir had already mentioned, if it is extensive, very extensive, then I think we can go for a radial forearm flap also. So that will cover a huge area. And apart from that, nasolabial flap, if there is enough tissue that can be harvested, I think nasolabial flap is a very good flap. Platysma flap also can be used. I have seen our teachers use it has a very good result. So that also gives us a good amount of tissue and skin also. So platysma is a good option if for an OSMF going for a free flap is not a great idea. So I think we can manage with the local flaps, which has a very good result.
Yes.
Right. Sreejith, sir, I think there are no more questions. Anything else anybody would like to add?
And even submental flaps, so that is also a good flap for such cases.
That is if you want to do extensive resection and reconstruction. Okay. Okay. I think there are no more questions, and I think we can wind up for the day. So thank you, Dr. Janani, and thank you, Sreejith, sir, for moderating the session. Thank you. It was you have done taken a lot of effort to prepare this presentation. Thank you so much for that, and you presented it very well. And I hope you'll share some of the articles which you have shown. I think most of us need to update, especially the postgraduates and even the faculties. We need, if you could share some of the
Yes, sir. I'll be very happy to.
articles.
I can create a Google Doc, sir. Google Doc, and then I'll put all the articles which I have quoted here, and then I can share the drive links, sir.
Yeah, that will be good. Thank you so much. That will be good if you can do that. It will be useful for the postgraduates, and you have included a lot of recent stuff which has come up.
Sure, I'll do it.
Thank you all for attending today's webinar. We'll be having the next webinar in the month of May. So please do join us. Thank you all. Have a good night.
Thank you, sir. Good night.